All right, so let's begin. This assignment says this was a hematology assignment that was due to be submitted by Thursday, 18th July 2024 at 5 p.m. So 5 p.m. is just time, your time or my time. That's okay for me. But this is short answer assignments. We have also some other kinds of assignments, that is multiple choice questions. But this one is a short answer, which is a good one to actually to strengthen our reading. All right, so the first question is, what is the main characteristic of stage 1 iron deficiency? It is not anemia, but iron deficiency, stage 1. What's the main characteristic of this stage 1 iron deficiency? Yes, you can just raise your hand or just open your microphone, but it's better to raise your hand in order to avoid collisions. What is the main characteristic of this stage 1 iron deficiency? Yes, someone. Yes, Joy. I think Roland or Joy is the one who even opened the microphone. Yes, please. Good evening. Yes. Yeah, thank you. So what is happening in stage 1 iron deficiency? It is not an overt anemia, but it is the progressive loss of iron. In fact, what is happening here is that what is being lost as iron is a stored iron. It's actually in storage compartments. That's the first thing that happens when someone is not getting adequate iron in the body. So there will be progressive loss of storage iron. So that's the first thing. And so the second question asks, in the stage 2 iron deficiency, RBC production continues as normal, relying on the iron available in. This is stage 2, but not stage 1. So, in fact, in stage 2 also, anemia is also not apparent as well, but RBC production continues as well, but it is relying on which iron available in which compartments, which and which. Faith, are you okay with this question? Faith? Because I see your hand is still up. Yes, Joy, do you have something to say? Okay, then let's have someone else to say this to answer this one. Yes, Helen. I think this, but yeah, she's Ellen. Yes, Ellen. Yes, Ellen, you can hear you. Which storage, which area, which source of iron in stage 2 iron deficiency? Maybe I think we could have someone else. Bright, kindly. Which compartment? The first compartment that is being consumed in stage 2, transport compartment, and then. Okay, so that's the iron that is being used in stage number 2 iron deficiency. It is also not anemia, but you're talking about only iron deficiency in stage number 2. The iron that is being used, it is iron in transport compartments, of course, transferrin, of course, and then the recycled from dying cell. Of course, it is not storage, but for example, iron from macrophage. Iron macrophage is the one that damage a dying RBC. It can also store some iron. That iron is being transported by what we call ferroportin, and also, of course, transferrin. So that is going to be used during this depletion of storage, because storage, there is a loss of storage in stage number 1. Then when storage number 1 is already depleted, storage is already depleted in iron deficiency stage 1, there will be use of iron from transport compartments, and even that iron which is being acquired from recycled dying cells. So then the third question says, why do both serum transferrin receptors and free erythropoietin protoporphyrin increase in stage 1 but absent in stage number 2? So this one was a mistake. I wanted to put stage 1, stage 2 here, and stage 1 here. In fact, the question was asking, yes, why do both STRIFL and FEP increase in stage 2 but absent in stage 1 iron deficiency? So that's when I corrected it as a mistake. I saw it. I was supposed to put 1 here, 2 here, and then 1 there. Stage number 1, this is not there, but in stage number 2, there is increase of the STFR and AFEP. Why? Let's say it is stage number 1, stage number 2, but absent in stage number 1. So what do you think? That one I corrected as a mistake. Well, yes, Frank, what do you think that these two things increase in stage number 2 but absent in stage number 1? Yes, you are audible. Yes. Okay, that's good. In fact, what I would also add is that we are talking about the serum transferrin receptors and also free erythrocyte protoporphyrin. Yeah, the two things, the two proteins increase. They are just receptor. One is receptor, another one is just protoporphyrin, which is heme precursor. So both of them, they are normally found in plasma in case there are maturing blasts which are iron starved. They are iron starved. They are starved of iron, and they need iron, and they are starved. And this normally start to happen in stage number 2, because of course that's where you can see also that hemoglobin is reducing in reticulocytes in stage number 2, but not in stage 1. So that's why you never find these receptors in plasma unless the cells are starving. They are iron starved, so they are starving. So that is why we find them only in stage 2 and stage 3, but we don't find them in stage 1. So that's what would be our answer on that question. Thank you so much. And we have also another question that says megaloblastoid features are seen in both. This is both in both myelodysplastic syndrome and megaloblastic anemia, and lists at least 4 distinguishing characteristics of the macrocytic erythrocytes in myelodysplastic syndrome from those in megaloblastic anemia. So in fact, of course, you can see that in both syndromes, we find megaloblastoid features, but we have at least 4 distinguishing characteristics of the macrocyte cells in MDS from those macrocyte cells in megaloblastic anemia. So just trying to distinguish between the two based on the features of those macrocytic cells in both syndromes. Yeah, what do you think can help us to distinguish? Because as you remember, just an additional information is that megaloblastic anemia is the only anemia that requires bone marrow examination in order to evaluate the cause of the anemia. In fact, we don't need bone marrow examination. Sometimes we could need it also in sideroblastic anemia, but megaloblastic anemia is the classic anemia in which we require bone marrow examination to make a diagnosis. So we do it because we want to distinguish between megaloblastic syndrome and myelodysplastic syndrome. So now, what do we see in terms of RBC morphology and features? Yes, please. Yeah, it is quite long question, but I hope that we can be able to. Someone else apart from Joy, I think. How is this person? Yes, Helen. Helen. Yes, Helen. Yes, please. Good evening. Vacuole. Yes, please. Nuclear budding. Okay. All right. Thank you. They are the 4. Thank you so much, Helen, for actually Helen was one of those who got a very high score in that one, because and that's the thing, that everybody that I put something congratulations, I was asking you to book your exam soon. Book exam and do it as soon as possible. You don't need to wait, because this is just exam and this is science. Sometimes you have to use it when you still remember everything, because you cannot remember things forever. So like when you are able now to read and try to answer questions like this one, you are really ready to go. Now, those are the 4 distinguishing characteristics that we can only find in myelodysplastic syndrome, but we cannot find them in megaloblastic anemia. The first is cytoplasmic evacuation, of course, nuclear budding, the budding of the nucleus, and also multiple nuclei. So that's what we call multinucleation. The 4th one is nuclear fragmentation. So those 4 features are not seen in megaloblastic anemia, but they are seen in myelodysplastic syndrome. Question number 5 says, what are the distinguishing aberrant findings between congenital dyserythropoietic anemia and megaloblastic anemia? So we have also 2 other almost similar syndromes. The first syndrome is called congenital dyserythropoietic anemia, and the second is called megaloblastic anemia. So what are the aberrant findings that can help us to differentiate between congenital dyserythropoietic anemia and megaloblastic anemia, right? And that one is what it says. Yes, please. What are some of the findings that can help you to differentiate between the 2 conditions? Need someone to answer this question? Who is ready? Yes, Joy, are you ready for this question? Mhm. Okay. What are the morphological findings? Mhm. Oh. Uh-huh. Just Flank, do you have something to say on this question? Uh, mhm, 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 mhm. All right, thank you so much. That is true, and that is why I had to add what we call aberrant findings. So I wanted actually to emphasize on morphological abnormalities. That's what I wanted actually to bring here. I couldn't say distinguishing morphological findings. In fact, I was just trying to bring it there, but because talking about clinical history, it's just history, but because there was no maybe genetic aberration so that we could find there. So that's why I just wanted to mention about morphological aberrant findings. So those aberrant findings, as Frank said them, just very, very clearly and correctly. That is internuclear chromatin bleaching of the precursors, of course, erythroblast, plus binuclear form of the erythroblast as well, and also giant multinucleated erythroblast. So those are the three distinguishing aberrant findings that we find in congenital dyserythropoietic anemia, regardless of which type, and which will of course help us to distinguish between this and megaloblastic anemia. Thank you so much, Frank, for your contribution. And then we have something that's saying patient's laboratory findings of serum is 47 microgram per deciliter, and total iron binding capacity is 160 microgram per deciliter. And then we are being asked to calculate transferrin saturation. How do we calculate transferrin saturation? What is our formula, and what is our result? What is our formula actually? How do we calculate transferrin saturation? Yes, Dorcas. Yes, please. Yes, we want to hear from you, Dorcas. Dorcas, are you ready? Okay, maybe I think Bright can help us with that one. Capacity times 100. All right, thank you. All right. All right, 29.4 or just 29.375%. That is transferrin saturation. when you are given, of course, serum iron as well as the total iron binding capacity. So which means this desaturation is very low because of low iron, low serum iron. So it gives also the, of course, low total iron, low transferrin saturation in percentage. Thank you so much. That was question number 6. And question number 7 says, what is the first and sensitive sign? What the first and sensitive sign of iron restrictive or iron restricted erythropoiesis in iron deficiency anemia? So what is the first and a sensitive sign? We are having two terms: first and sensitive sign of iron restricted erythropoiesis in iron deficiency anemia. Okay, yes, Helen. Yes, I think Helen. Yes, Erin. All right, thank you. Thank you so much. So yeah, that's maybe I think this question was a bit tricky because there's some who didn't actually make it, which I was wondering why. Because the first and sensitive sign in iron restricted anemia, of course, that is an deficiency anemia, like what you can be able to test and be the first sign, because otherwise, until iron deficiency is in stage 3, iron is not, anemia is not yet apparent, right? Until stage 3. And you remember, serum, reticulocyte hemoglobin can be tested, and it will be very low even in stage 2, and it is easier to test than testing maybe serum transferrin receptors, because those ones are specialized tests. But reticulocyte hemoglobin can be tested and as a screening test, and it will be the first and sensitive sign of iron restricted erythropoiesis. Thank you so much, Helen, for your contribution. Okay, so now question number 8, it is asking, what is the indication of zinc porphyrin assay in restrictive anemias? Here I wanted to mean, why do we need to perform zinc porphyrin assay in any restrictive anemia? Why? What are we looking for? Why does a doctor request the zinc or ZPP, zinc porphyrin assay? That was just simply a question. Yes, please. Yes. Yes, Ellen. Go ahead again. Okay, yeah, that's correct. It is. Why do we need? Because that zinc is used in order to cherate porphyrin. In fact, that's why we use. It's just like assay, because there's no other way we can measure the amount of FEP or free erythrocyte porphyrin. So we use zinc porphyrin assay in order to measure or to assess in assessment of FEP accumulation. Thank you so much. So question number 10, a marked increase in MCV in megaloblastic anemia is a primary finding. Of course, that is correct. But what does paradoxically lower MCV in this condition? So you know that MCV is the first thing, is a great marker in megaloblastic anemia. But why? Why sometimes we find lower MCV in this condition? What the cause of lower MCV in a megaloblastic anemia? So what contributes to the lower MCV even in megaloblastic anemia, despite that MCV increase is the first and sensitive marker in megaloblastic anemia, if I can say. Yes, Frank. So your microphone is open, Frank. Mhm. 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 Okay. Yeah, that's correct. In fact, the presence of schistocytes. Yeah, schistocytes, because this, megaloblastic anemia is also a part of hemolytic anemia. So in case of that, there would be also the presence of schistocytes as like fragments of erythrocytes. So when that happens, of course, you'd see that even those one will be counted as RBC, and which will, of course, is going to decrease abnormally MCV in this condition. So that is why we find sometimes MCV is lower. Okay, so and explain the most critical steps at which lead poisoning interferes with heme biosynthesis, which may lead to porphyria. So which step? Maybe you can just mention the steps and just main steps and most critical steps. Yes, yes. Oh, we skip it. Oh, oh, sorry. Maybe just okay. Okay, thank you so much, Caroline. Question number 9. It was okay. Let's jump to question number 9 first, and then you continue. It was just about the hallmark or distinguishing characteristic in the diagnosis of sideroblastic anemia. And what is the hallmark in this condition in order to make diagnosis? The hallmark is just conclusive or distinguishing characteristic in in a certain condition. Yes, Karen, can you help us with this question? Because yes, please. Mm. Okay, the presence of sideroblasts in the bone marrow is so the sideroblasts are those cells that contain the nuclei. Of course, they are still blast, but the nucleus is surrounded by a mitochondria filled with iron. Of course, you find using Prussian blue stains, they will look blue. So that is you see them surrounding entirely the whole nucleus. But even if it is just 75% of the nucleus, you confirm it is a ring sideroblast. So that is the first thing you have to see and confirm sideroblastic anemia. Thank you so much. So we are just talking about lead poisoning and which heme biosynthesis steps that it interferes with the lead poisoning, the most critical steps in heme biosynthesis. Question number 11. Question number 11. Which steps, most critical steps? It can interfere with everything, but most critical steps in heme biosynthesis. Which I have seen that you have done it you have done it correctly in your assignment. And Frank, yes, Frank. Mm, 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 mhm. Yes. Thank you so much. That is correct. And here we're just talking about the two steps. These are the major steps, like most critical steps that you find that there is daily accumulation of, first of all, aminolevulinic acid, because it is aminolevulinic acid dehydratase is interfered by the lead, and of course, which leads to the accumulation of aminolevulinic acid. And the second step, it is also the incorporation of iron into protoporphyrin 9. In fact, this is performed by ferroteratase enzyme, so which actually helps the incorporation of iron into the protoporphyrin in order to form a finished product, which is heme. So then there will be accumulation of protoporphyrin in the mitochondria, and of course iron. So those are the two critical steps with which lead poisoning interfere. Thank you so much. So question number 12, it is the main cause of basophilic stipplings in lead toxicity. The main cause, or why, what is, what contributes to basophilic stippling formation in erythrocytes due to lead poisoning? Yes. Yes, Safia, what contribute to basophilic stippling? Okay, yes, sure, that's correct. Yeah, so that is the first thing is, of course, to recognize that the enzyme responsible for breaking down ribosomal nucleic acid and ribosomes in, of course, maturing cells. So it is also inhibited by lead poisoning or lead toxicity. If it is not able to break down RNA and ribosomes, they are going to accumulate in the cells as basophilic stipplings. So someone would say it is because of inhibition of pyrimidine 5 nucleotidase. That's not enough, because if that one happens, but there is no accumulation of RNA, there will not be any basophilic stippling. So basophilic stipplings, always you have to remember that what causes is accumulation of ribosome in any way that ribosomal RNA and ribosomes, their accumulation is the one that leads to basophilic stipplings. So, but not inhibition of the step is not enough, because if that accumulation does not happen, there will not be any stippling in RBC. Okay, thank you so much for that contribution, Xavier. Thank you so much. So now we have this 13th question, which asks, what are the main differential findings that distinguish macrocytic non-megaloblastic and classic megaloblastic anemia? We have the two conditions. One is called macrocytic non-megaloblastic and classic megaloblastic syndrome or anemia. Yes, Karen, what are the main differential findings? Mm. Mm. Mhm. Mm. Okay. Mm. Yeah, present. Thank you so much. And the main cause of macrocytosis is nothing other than reticulocytosis. There's a high number of reticulocytes. That is what contributing to the macrocytosis in non-megaloblastic anemia. Because in megaloblastic anemia, there are also problems of other cells you find there because of asynchrony that's happening. But in non-megaloblastic anemia, there would actually be the most common cause of this is just the presence of reticulocytosis. So question number 14 is just this illustration. Is just illustration, which is of course electrophoresis of hemoglobin electrophoresis, which is showing patterns in cellulose acetate strip, which is of course alkaline pH cellulose acetate, and it is showing the migration of hemoglobin A2, hemoglobin S, hemoglobin F, as well as hemoglobin A. And we have pattern A, pattern B, and pattern C, and pattern D, and also control. So that's how actual typical questions they come in this kind of format. So we are asking which electrophoresis pattern is consistent with the sickle cell traits. If you look at this, which pattern that is consistent with with the sickle cell trait. Yeah. So first of all, of course, it is to understand which bands that will be appearing on sickle cell trait specimen. Pattern A, B, C, D. And it shows this. Xavier, yes, Xavier is going to explain to us which bands now are representing sickle cell trait on this electrophoresis. It is a C. Okay, that one. All right. Thank you so much, Xavier. Thank you so much for that. Very, very smart. Very smart explanation. So we have this expression. As she was explaining, she said that we have to remember, for you to answer such question, you have to remember which types of hemoglobin that we find in certain disease, because we have hemoglobin trait. Sickle cell trait. It is not homozygous state. It is just heterozygous form of sickle cell. We must have, of course, in that homozygous form, we have 60% of hemoglobin is hemoglobin A, right? 40% is hemoglobin S, right? Is an abnormal hemoglobin S. And some of it, of course, a few like normal percentage, which means like about 3, 5, 2 to 3, like that. It will also be occupied with the hemoglobin A2, because that is delta and alpha. So it has nothing to do with the beta, because it is just delta and alpha. That is hemoglobin A2. So in that case, now you have to look at this illustration, and you have to try to check where do we find all the 3 types of hemoglobins: A, S, and A2. AS and A2. So you find them only on pattern A. Pattern A, it shows all of them as 3. But if you look at pattern B, there's no A. If you look at pattern C, there is F, and you remember F is not there. And of course, there is no S at all. that also exclude pattern C. Pattern D is also excluded definitely because there is no S here. So that is why we chose pattern A, because it has all those types of hemoglobin in the thread. Thank you so much. So now question number 15, it is asking, what is the hallmark in the diagnosis of sickle cell disease? What do we find as differential or confirmatory diagnosis feature or finding in order to diagnose sickle cell disease? Sickle cell, what is the hallmark in the diagnosis of sickle cell? Yes, Caroline, go on, please. Go on. It is your turn. Okay, thank you so much. We find target cells, those cells with the target in the center, as well as sickle cell, of course, banana shape or sickle cell in diagnosis. So, which means on your peripheral blood smear, if you find the two, can help you to continue with the confirmatory test. Of course, that is electrophoresis or high performance liquid chromatography, but of course you have to go through also solubility testing. But peripheral blood smear, you can just use the two, just they can help you to diagnose sickle cell disease. And what is the etiology of hereditary spherocytosis now? What causes hereditary spherocytosis? What is the etiology? What is the etiology of hereditary spherocytosis? Frank, is microphone is on? Yes, please. Yes, Frank. Mm. 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 Okay, great. Thank you so much, Frank. That is really correct and 100% correct. That these are just like disruption of vertical interaction. And what is the vertical interaction? It is just transmembrane protein that should link to the underlying protein cytoskeleton. And because of the abnormalities in the synthesis of those transmembrane proteins, of course, the link, the interaction will be disrupted, which of course leads to hereditary spherocytosis. Okay, so then what are the three key manifestations of hereditary spherocytosis? Three key manifestations of hereditary spherocytosis. What are the, yes, Ellen? What are the three? Ellen? Yes, Ellen. I think we have two Ellens here. But I think one is from Uganda, one is from Kenya. Ellen, from the other side, Kenya. Yes, please. All right, thank you so much. Splenomegaly, anemia, and jaundice. That is great. Those are the three key manifestations. So maybe there's no need of putting hemolysis, right? Because hemolysis is also found otherwise, because hemolysis leads to anemia. By the time you diagnose it, you find the anemia is there, and also jaundice and splenomegaly because of extravascular hemolysis taking place. Thank you so much for that. So apart from the spherocytes in hereditary spherocytosis, what are the other RBC morphological abnormalities would you expect apart from spherocytes? Are there other RBC morphological abnormalities? Yeah, we're talking about RBC, but not really clinical features. RBC, other RBC morphological abnormalities that you find in hereditary spherocytosis other than spherocytes alone. Caroline? Yes, let's go on. Okay. And mushroom-shaped RBC, isn't it? Mushroom-shaped RBC. They're called penciled cells or mushroom-shaped RBC. They're also found plus acanthocytes plus also oval stomatocytes. So those are also found in hereditary stomatocytosis. Apart from spherocytes. Now, and how do we confirm hereditary spherocytosis? How do we confirm? What are the confirmatory findings? Confirmatory findings in hereditary spherocytosis. What do we actually use to confirm? Yes, Frank? What do we use to confirm? Okay, thank you so much. Thank you so much. The other further test, but of course, if these things are available, then you can confirm hereditary spherocytosis, isn't it? If family history, splenomegaly, high MCHC, latest count high, spherocytes on peripheral blood smear, then if we have all of them, then no other test you need to run. Otherwise, unless you don't find some of these features. So yes, so that's okay. When you have them, then no further test is required for hereditary spherocytosis. So we are going to that question where you don't find some of those features. All right, thank you so much. So 20, explain the mechanism in formation of schistocytes in microangiopathic hemolytic anemia. The formation of schistocytes. We are talking about microangiopathies, hemolytic anemia. What the mechanism of the formation of these schistocytes? Yes, Helen, from Uganda. No, right? Well do. Okay, thank you. So it's like mechanical sharing, mechanical destruction of RBCs as they're passing through small blocked small blocked vessels, isn't it? Like capillaries. So that kind of sharing and also resealing of RBC that leads to schistocytes. Thank you so much. So explain special methods performed in case these things that Frank was talking about are not seen, are not clear. For example, family history is not clear and the mode of inheritance is not clear. In case of hereditary spherocytosis, what other methods that we run? So we can just list them because they're just long story to explain them. You can just list those other methods, other special methods we perform in case we don't find those manifestations. Yes, Caroline. All right, thank you so much. That is sodium dodecyl sulfate polyacrylate amide gel electrophoresis. That is SDS page. It's called SDS page, and osmotic flagellity and eosin 59 maleimadine binding test. So those are the tests that we perform as special tests in order to confirm or to diagnose hereditary spherocytosis in case family history and mode of inheritance are not clear, or some other atypical findings are seen. Okay, thank you. So now, why microangiopathies, hemolytic anemia, they are also called thrombotic microangiopathy? There's just one single sentence for this question. Why is microangiopathies, hemolytic anemia is also called thrombotic microangiopathies? Yes, Frank, what is it called thrombotic? Yes, so that is of course correct. It's called thrombotic microangiopathy because thrombi formation in microvasculature, of course, in small vessels, it involves consumption of platelets, and of course, the consumption of platelets will lead to thrombocytopenia. That's why we call it thrombo. Where is it? Thrombotic microangiopathy. Yeah, because of the use of excessive use of platelets or thrombocytes. So, and what is a specific etiology of thrombotic thrombocytopenic papilla? Thrombotic TTP, thrombotic thrombocytopenic papilla. So, what is the etiologic cause or etiology of this condition? Question number 23. Yeah, we go, Helen. Yes, Helen. Hands up and go on, please. Okay, von Wellman factor, of course, cleaving protease. That is simple, and that's simple and good. So, of course, that protease has got a very long name, which is called a disintegrin and metalloprotease with the thrombospondin type 1 motif, member 13. That is how we call it. So that is a cleaving. It is a protease, of course, which is enzyme that cleaves methylmeric von Willebrand factor to its functional monomeric molecules. So if it is not available, then there will be a problem of thrombotic thrombocytopenic papilla, because in this case now platelets are not able to adhere to the collagen. How can you differentiate between thrombotic thrombocytopenic papilla and disseminated intravascular coagulation? Just one small sentence. Can we differentiate? Yes, Caroline, how can you differentiate between the two conditions? Mm. Okay. Mm. Okay, thank you so much. So that is, of course, just very important, and of course, and a very important additional point is that, as you remember, we have two types of coagulation. I mean, normal hemostasis, which is primary and secondary hemostasis, and in a thrombotic thrombocytopenic papilla, there is only activation of primary hemostasis, which of course involves blood vessels and platelets. and in a disseminated intravascular coagulation, there would be activation of secondary hemostasis, which involves coagulation factors and of course fibrinolysis. That's why she also mentioned the D dimer, because D dimer are the products of fibrinolysis. Thank you so much, Karen, for that great answer. So how can we, and then what is the treatment approach of autoimmune thrombocytopenic papilla? Uh, yeah, that was about, it was somehow confusing, but I don't want you to be confused. I will explain why. What is the treatment, the approach of autoimmune thrombocytopenic papilla? Yes, Frank. Yes, Frank, you are there. Mm, 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 mm. Yes. Okay. Yes. Thank you so much. Because I did not hear a full stop. That's why I was still waiting. Okay. Okay. All right. So, yes, that's true. Yeah, because I was still waiting for the full stop. Now I missed where we are, but we are in question 25, I think. Yes, we are. In fact, there's some people were responding corticosteroids. We use them. Those are like anti-suppress, like mean immunosuppressant therapy. Uh, it is sometimes also approach for some of the autoimmune conditions, immunosuppression, but those cannot be the first approach, because it is very important, first of all, to remove the offending autoantibody. But also, it is not really enough as well, because those autoantibody are still produced even after exchange of plasma, because that is immune problem, immune derangement. So even those autoantibodies, we can remove them completely from body, but still they'll be sensitized later. But in conjunction with corticosteroids. But the first approach is to transfusion of fresh frozen plasma, which contains, of course, a good that why ADMTS13 enzyme. Thank you so much. So, and what a drawback, the major drawbacks of splenectomy in hereditary spherocytosis. The drawback of splenectomy, drawback, of course, like complications or bad sides of splenectomy. Yes, yes, Joy. Yes, Joy, please. The major drawback, the major drawback, okay, is overwhelming sepsis. Mm. Okay, yeah, those are the drawbacks. Thank you so much. The two major drawbacks. Uh, the two major drawbacks is, of course, overwhelming problem of sepsis, and because of encapsulated bacteria. And then another thing is also risk of cardiovascular disease with age. Those are the two major drawbacks of splenectomy. Because after you remove the spleen, how do you think bacteria will be removed easily from blood? So that can cause sepsis. And question number 27, what is etiology of hereditary erythrocytosis now? Hereditary erythrocytosis, what is the etiology of this condition? Hereditary erythrocytosis. Mm, uh, Joy, is your hand still up? Okay, thank you so much. Yes, Joy. Yes, Caroline. Yes, please, Caroline. Mm, mm, mm. Okay. Mm, mhm. Oh, okay, thank you so much. So that is hereditary eptocytosis. Of course, unlike hereditary spherocytosis, where the disruption linkage is between transmembrane proteins to the cytoskeletal proteins inside the cell, here a problem is linkage between just only cytoskeleton's proteins within the cells. Transmembrane is not involved here. So that's why we call it horizontal interaction disruption. So which leads, of course, to the erythrocytes, the cell, those ones that are like rods, they are long cells. And then before we leave you, Caroline, and what is cigarette shaped RBC? In which condition do we normally find cigarette or cigarette shaped RBCs? Yes, the same. We find the cells are very long, like cigarettes, so call them cigarette cell in this condition. I think I've had someone try raising hand. Or yes, we are okay. Okay, now we are about to finish our task. Now, why wouldn't you recommend the splenectomy in overhydrated hereditary stomatocytosis? Why splenectomy is not good in this condition? Overhydrated. Overhydrated is about electrolyte, isn't it? Overhydrated hereditary stomatocytosis. Why splenectomy is not recommended here? Yes, S. Ellen, why do we not don't we recommend it? Uh, all right, so we don't recommend because it is associated with a serious problem of thromboembolic complications. Thromboembolism, we know the thromboembolism in blood everywhere, so that is very life-threatening condition. So that's why we never recommend this splenectomy in hereditary overhydrated hereditary stomatocytosis. And then, how can you differentiate a typical and typical hemolytic uremic syndrome based on their etiology? Just in two sentences, how do you differentiate uh, a typical from typical hemolytic, yes, flank hemolytic uremic syndromes? Mm-hmm. 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 Okay, thank you so much. Just the simple difference, as he explained, is that one is caused by bacteria, toxin of Escherichia coli, and which is of course the 0157810. So that is the typical hemolytic uremic syndrome, and a typical one is just misregulation of complement cascade, which leads to this hemolytic uremic syndrome. And then how do we define the etiology of the HELP syndrome. HELP syndrome is about hemolysis, increase in liver enzymes and everything, and platelet, low platelet, and so on. So that's what we call HELP syndrome. What is the main etiology of this HELP syndrome uh, in pregnant women? Of course, what is the the etiology of HELP syndrome? Mm. What is etiology of HELP? Yes, 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 yes. All right. Mm-hmm. Mm-hmm. Mm. That is preeclampsia, isn't it? Mm-hmm. 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 Okay. Now I've seen the theology. I've seen the theology, and that's how we differentiate between HELP syndrome and preeclampsia. In fact, HELP syndrome does not occur before the endothelial dysfunction, which is not seen in HELPs in preeclampsia. In preeclampsia, there's nothing like um, endothelial cell dysfunction. So this endothelial cell dysfunction, total dysfunction of endothelial cell, it is what leads to platelet activation. And remember, immediately after platelets are activated, there will be also uh, fibrin deposition in the microvasculature of everywhere, but especially in the liver. So that's why you find that in HELP syndrome, there will be consumption of platelets, but together with liver enzymes, high liver enzymes. But the two things are not seen in preeclampsia. So high liver enzymes and platelet consumption are not seen in preeclampsia. So before that one happens, there would be preeclampsia as a precursor of HELP syndrome. But before problems of endothelium happen, there's no HELP syndrome yet, because HELP syndrome is characterized by platelet activation and of course consumption plus liver enzymes and of course hemolysis, because that's what is going on. Thank you so much. That is the of course the etiology of that. It is first of all the precursor, which is a preeclampsia, and dysfunction of endothelial cells, which leads to platelet activation and disturbance or destruction of liver, which leads to high liver enzymes. Thank you so much for your contribution. So that's one is, I think, is clear. Okay, then what are the major diagnostic criteria for HELP syndrome? Um, yes, yes, Caroline. What are the major criteria? Yes, that was you. Mm, mm, Mm. Yes, and also, and of course, sign of hemolysis, which is increase in lactic acid dehydrogenase, isn't it? LDH. It also increase because it's a sign of hemolysis. Okay, so why do we find PT and APT within reference range in HELLP syndrome? Mhm. Uh, yes, again, Karen, why do we find the two in reference interval in HELLP syndrome? Mm. Yes, yes, yes. Okay, so that is true. That HELLP syndrome is just a acquired platelet consumption syndrome, and of course, which leads to thrombocytopenia. And thrombocytopenia does not involve PT and APTT interference. So then bleeding abnormality that is seen in HELLP syndrome is associated with low platelet levels, but not coagulation factor function or just coagulation factor levels, right? So that's the cause of bleeding that is manifested in HELLP syndrome. So, and what is the etiology of dehydrated hereditary stomatocytosis? Etiology of dehydrated hereditary stomatocytosis. Yes, Xavier, what is the etiology? Mm. Mhm. All right, so that is true. Yes, that is true. It is a problem of cation permeability that causes the leak of water from the cell to environment outside, and it leads to, of course, dehydration of RBC. So that is the cause of dehydrated hereditary stomatocytosis, which is also called hereditary xerocytosis. The last one, it is about the factors contributing to the acquired stomatocytosis, which is the last question here. What are the contributing factors to acquired stomatocytosis? Yes, Ellen, that is, thank you for, yes, yes, please. Mhm. Okay, thank you so much. So those are associated with acquired stomatocytosis. Thank you so much for your contribution, and I really appreciate. Actually, I was missing this time. You know, it has been some time, but I was really missing this time. It is really helpful and is very good interactive session, which I hope is going to help us and to improve, of course, uh, our levels and our our reading pace and our reading status, because this actually helps also. It help us, or it stimulate us to open content and read. So I thank you so much, and of course, I think you are most of you actually should apply and get exam date and pass exam, because I know are going to make it. Because sometimes when I'm comparing, I compared myself the time I wrote this exam, and obviously and frankly I passed with very high score. But maybe I was not at this level, yeah, at which you are. So, and I wish you all the best in your preparation, and of course, I really appreciate that I send these long assignments and you take time to read and uh,